and you'll get a evaluation link that's in the chat right now. Please click on that and complete it to receive your continuing education credits. And I don't have anything else. Whitney, do you want to go ahead and share your slides, or do you want me to share your slides?
I'll share them.
Okay.
Okay, so thanks for having me present today about syphilis. I am a Whitney Essex. I'm a nurse practitioner. I work in infectious diseases and have for a long time for the Cherokee Nation in Oklahoma. So glad to be talking to everybody today. All right, so let me see, share here. Can you see my screen, Brian? Give me a thumbs up. Yeah.
Yep.
Good. Okay. All right. Let me see if I can see my screen. All right. So we're going to talk a little bit about, we're going to touch on several pieces of syphilis information today. We're looking at the epidemiology, the most recent information that CDC has available. We'll look at testing and screening, who to test and how often to test them. We're going to talk about staging of syphilis, which is really important. I feel like that's a common question that I get as a consultant on syphilis cases is, you know, which stage of syphilis somebody can be classified in. We'll look at the lab testing for syphilis and how to interpret those results. And then we're going to touch just barely on treatment. This is a lot of information, I will say, for this short time. So I do encourage your questions because I'm going to have to kind of be brief in some of the explanations. So you guys let me know where I need to fill in the gaps, okay? So in 2012, you can see that there were a couple of states on the left there that had high numbers of syphilis reported. One was actually the District of Columbia, and then there was Puerto Rico had a pretty high rate of syphilis. Looking at 2021, what a huge difference we have seen in our syphilis cases. So lots and lots, the darker the color on this map, the more cases of syphilis, and man, it has just really exploded. As we go, why don't you guys enter into the chat if you are seeing increased syphilis cases at your site? Okay, I want to know that so I can go back and look. I can't see the chat right now, Brian, so you'll have to stop me if there's any questions, okay? All right, and then this statistic is really concerning to us, of course, working with the American Indian Alaska Native population. These are rates of reported cases by race and ethnicity in the U.S. from 2017 to 2021. This includes primary and secondary syphilis. So just keeping in mind, this is not looking at late syphilis. So these are cases of primary and secondary. Huge increase. The biggest increase by race was in the American Indian population, and it's just really concerning. So much more syphilis that we're seeing in our community for sure, and I think that's pretty standard across the board for Native American communities. One of the more troubling statistics is this congenital syphilis statistic. Again, huge increase in congenital syphilis, and how awful congenital syphilis is. If you haven't seen it, haven't experienced it in patients, it's just really, really bad. So we are working to get these numbers lower, and that's where our testing and screening comes in. So let's look at who to test or screen for syphilis. So of course, anyone who has classic symptoms is going to get a test for syphilis. But sometimes syphilis, it's known as the great imitator, the great masquerader. It is easy to miss syphilis in patients who don't have classic symptoms of syphilis. And we're going to talk about some of those symptoms today. But any patient who is coming in with something weird that you can't really explain should be tested for syphilis. And then, of course, any patient who's at risk, who has risk factors for getting syphilis, should be screened for syphilis. Let's look at this case. So this is actually a picture of a young Al Capone that you see in this picture. He's famously or infamously had syphilis. So you have a 23-year-old male who comes to your clinic for just routine testing. His partners are male. He was tested for HIV 3 months ago, but has never been tested for syphilis as far as he knows. He's had several new partners in the last month. He's got no complaints. So he's asymptomatic. He's just coming in for testing. Which of the following would you perform during this visit? And you can either enter in the chat, or you can just think about what your answer would be. Just for the sake of time, I'm going to move on and say that, of course, this answer is going to be all of the above. You're going to want to screen him for HIV and syphilis. You're going to take a sexual history and do a quick physical clinical exam. All right, so who to test? Anyone who has a classic symptom of syphilis should be tested for syphilis. Painless genital ulcer is very, textbook for primary syphilis. Any patient who has a rash, that patient should be screened for syphilis. And then in tertiary syphilis, we see general paresthesias, or there are some other symptoms that we'll talk about on our next slide. But things like cranial nerve dysfunction, headaches, meningitis, patients who have uveitis, and one of the most kind of surprising things that I see for consults for syphilis are referrals from our optometrists. So they'll be working a patient up for uveitis, and part of their workup for uveitis includes an RPR. And many, many times they'll send us a patient and say, "Hey, found out this patient has optic or ocular syphilis," and so that can be one of the presentations. Some other things: patient comes in with acute hepatitis that you can't explain otherwise, needs to be tested for syphilis. Renal problems like nephrotic syndrome, and you have no cause, that should be a patient who gets tested for syphilis. And then there is such a thing as cardiovascular syphilis. This happens years and years, many years after initial infection, but they can have aneurysms or aortic insufficiency, and even myocarditis. So in asymptomatic individuals, I'm going to look at the big picture, which this is from the CDC treatment guidelines on screening recommendations for the STD guidelines. And this is who CDC recommends get screened for syphilis. Any women should be screened for syphilis if they're asymptomatic, but they have an increased risk. So things like incarceration, if they are sex workers, by geography, or by race or ethnicity. So keep that in mind. Our AIAN patients are in this high risk group just based on race alone. So what this tells me as a provider is that really all of my female patients should be screened for syphilis. Pregnant women at every first prenatal visit, and then again at their 28 weeks gestation visit, and also if they're at high risk, potentially more frequently. And this goes along with that congenital syphilis. When a woman gets syphilis in the third trimester, it can it crosses the placenta and it can cause fetal death and a myriad of other problems. So we always screen in the 3rd trimester as well as the first prenatal visit. Men who have sex with women should be screened. So asymptomatic, but they have either a history of incarceration, sex work, and again, here we see the race ethnicity groups. So we know that the AIAN population is at risk. And so all men who have sex with women should be screened for syphilis. Men who have sex with men, this should be done annually and then every 3 to 6 months as needed based on their risk. And then of course they fall into that same category that I just mentioned above. For transgender or gender diverse people, consider screening at least annually. This is going to be based on all of the above as well. And then persons with HIV should be screened at their HIV visit, and then at least annually and as needed for risk factors that have been mentioned above. Okay, so I included a few other tables that you'll have for reference because Brian has these slides and he can make those available for everyone. But I'm going to move on to staging syphilis. I just want to look at my time here. Okay, so staging syphilis is, like I said, it's one of the more common questions that we get when it comes to syphilis consultation. So let's look at this, look at the slide in this graph, and we'll look at the clinical stages of disease. Because syphilis is a persistent disease, we break it up into stages. So you can see you have a primary stage. This is the time of localized infection. This patient may have a chancre. It is usually just a single chancre. It's usually not painful. It is at the site of contact. And this precedes the secondary symptoms. It resolves without treatment. It just goes away on its own. It can be very tiny. It can be large. And then moving on to the secondary stage, this is the time of systemic infection. So secondary infection occurs anywhere from a few weeks to 6 months after exposure. It typically presents as a rash. We're going to look at some pictures of that rash. It is the textbook version of the rash would be maculopapular, but it also can occur very often on the palms of the hands and the soles of the feet. So anytime, I used to work in the urgent care years ago, and patients who would come in with a palmar rash, your first thought should be syphilis, and it looks almost annular when it's on the palms a lot of times. So it looks fungal, but it is most likely syphilis in that case. Systemic symptoms can be prolonged. They can kind of mimic acute HIV symptoms. So things like fever, headache, malaise, lymphadenopathy, sore throat. You may see weight loss, alopecia, especially patchy alopecia. So patients who have alopecia areata, a lot of times you should be thinking to screen them for syphilis, because that can be a presenting factor for secondary syphilis. I will say that not all patients who are infected with syphilis will be symptomatic, even if they do not get treated. So a lot of times patients will not have symptoms of the localized or the systemic infection. Moving on to tertiary, so the immune system starts causing problems because it's recognizing the presence of syphilis. It can cause damage to the brain, including symptoms of dementia. It can cause a weakened aorta, which leads to problems, of course, there. It can cause pupillary changes, bone inflammation, and the list really goes on and on. So syphilis, bad news, can cause lots of problems. And let's look at a little more detail at these stages. So warning, some of the next slides are a little bit graphic, but definitely necessary for our group. So, all right, we have, in this slide, you have the primary chancre that we talked about. So this happens usually within the first couple of months or a few weeks after the syphilis exposure. And these ulcers are painless. However, I will say I have had patients swear to me that they are painful, and given the location, I can understand, and maybe they are painful for some patients, but most are painless. Oh, I didn't remember that these. I thought my pictures didn't show up, but they just come one at a time, it looks like. So, so looking at these pictures, these are a little bit different, not as clear cut as a ulcer that's on the penis, and many times missed because these chancres in women can be up in the vaginal vault or on the vaginal walls, and so you may not ever. It's very common for women to never know that they have a chancre because they are painless. So so just keep that in mind when you're educating patients about their positive syphilis tests, that many times, you know, the woman will say, you know, I swear I've never had a lesion, never had anything abnormal, but because they're painless and they can be on the inside, they may not have known. And that's actually very common. Okay, so looking at secondary syphilis, we're going to see more of this rash presentation. You can see here there's a palmar rash that looks annular, and then sometimes the rash can be more localized to the area of contact there, you can see. And this is the scrotal rash you see. This is sometimes patients will come to me thinking they have a fungal infection, and that's actually the secondary presentation of syphilis, secondary stage. And then here you can see this is on the face of a patient, just another presentation, another way the syphilis rash can present itself. Okay, so less common is the picture on the left. You see the condyloma lata. That's not to be confused with the condyloma that can occur with HPV, but it does look kind of similar. It's just a grouping of clustered moist lesions. They kind of ooze. You can see in the second picture that some alopecia that's patchy, which can be a sign of secondary syphilis. And then these mucus patches that they kind of can scrape off just a little bit, but they don't go away until the syphilis has run its course. All right, so let's go back to our case. So you get a sexual history, you send off for labs, you do a clinical exam, and you notice on clinical exam that there's this shallow painless ulcer with firm borders. It's on the genital area. And how would you stage this patient? So this is pretty fresh on our minds, right? We're going to stage this as a primary syphilis case. All right, so case number 2, we're going to talk about Lisa. This is a 23-year-old female who presents to the clinic for routine STI screening. You take a sexual history and you find out that she is married but has multiple sex partners. She has multiple sites of exposure, so oral, vaginal, anal. Sometimes uses condoms and has no previous history of STIs. So you look at Miss Lisa, and you notice that she has this palmar rash, and she also has a lesion on her tongue. Based on your exam, you would suspect what stage of syphilis? So in this case, also very fresh, this is going to be secondary syphilis. And I think that, so far, as far as the ease of understanding syphilis, this is really the most cut and dry. So symptoms, we match it up with the stage, and that's pretty simple. Now, moving on to latent syphilis. So in latent syphilis, the patient does not have symptoms. So the only way for us to know about latent syphilis is by screening the patient. And because there's no symptoms, and the patient maybe never had symptoms or didn't know they had symptoms, because I will say the syphilis rash, secondary syphilis rash, it goes away on its own without treating syphilis. So it will go away anyway. It doesn't stay. It doesn't stay until you get treated. It just goes away. And so that patient may have just thought they had a rash, and they never seek treatment for it, and it goes away. So they think it was nothing, and they don't know they had syphilis. So for those patients, the only way that we will know that they have syphilis is by screening them. So for latent syphilis, we divide it into early or late, and it's a matter of time between the normal lab tests that you have. So if they've ever had a screening test for syphilis that was negative, then you would know that they were negative at that point, and you use the timeline of less than 1 year or greater than 1 year. But otherwise, if it's unknown or you don't know that, then you really are just considering it a latent infection. So worst case scenario, they've had this a long time, it's been untreated a long time, and that's how we treat them. All right. So one thing that I want to mention about tertiary syphilis. So tertiary syphilis can occur actually at any stage of the latent syphilis, because with tertiary syphilis, in every case of syphilis, no matter if they end up having known neurosyphilis, meaning that it has invaded the central nervous system, it may not cause immediate problems, and 25% of cases of syphilis actually do. If we tested we did an LP on everyone who had syphilis, 25% would have syphilis in their central nervous system, but it resolves on its own, or it resolves with treatment of the earlier the primary or secondary syphilis, so we don't really know it. But sometimes the syphilis can go, when you're in latent syphilis, you can have CNS invasion. It's asymptomatic for a long time, and then suddenly the patient comes in with symptoms. So it can go long time, or it can be in the early stages that you see even neurosyphilis. When you have a patient who presents with syphilis, even if it's just on screening, when they didn't have any symptoms, you're going to want to make sure that you screen them for neurosyphilis. So screening for visual problems, any changes in their vision, double vision, headaches, hearing changes. Have they had any hearing loss or tinnitus? Anything that you can consider to be a potential central nervous system symptom needs to be evaluated, because the treatment for neurosyphilis is different. We use IV penicillin for neurosyphilis treatment. And if a patient with neurosyphilis gets treated as a latent syphilis, then they will likely not be cured, and they can still develop neurosyphilis down the road. which can be really debilitating and cause permanent damage and even death. All right. So, Brian, are we okay so far for questions?
Yes, there was one, but I think you answered it. It was, will a pregnant patient automatically be screened during prenatal care?
Okay, yeah. Yeah, so most prenatal that first visit includes a syphilis screening if you're doing like bundles of testing. But if not, it definitely should. So yes, prenatal visit number 1, every patient should be screened, and then 28 at their 28-week mark as well. So that 3rd trimester. All right, so let's look at the tests that we have for syphilis. In general, there are 2 types of tests for syphilis. So the antibodies that can be detected are either considered treponemal or non-treponemal tests. So the non-treponemal test, which is the RPR, this is a rapid plasma reagent. It looks for the non-treponemal antibody. It is released in the bloodstream when the organism causes damage. These levels go up when there's more active disease. They peak during the secondary stage of disease, and then they fall after about a year's time, even if the infection is not treated. These levels get measured by what we call a titer, and the higher the titer, the more active the disease. So historically, we've used RPR to screen for syphilis because it's cheap, it's easy to do. But when we're looking at a treponemal test, it is more sensitive and more specific than the RPR. So once infected with syphilis, the treponemal test will be positive for their lifetime. So we can use this for screening, but we really can't use it for staging of syphilis. So we can't tell the difference between a current or a past infection when we only use a treponemal test. So these tests used to be more expensive. They're becoming cheaper, and they're now being used as screening tests in many clinical settings. I would be interested to know what tests you guys are using. If you want to type it in the chat, what test you're using for syphilis screening, if you're using the RPR or if you're using something, treponemal tests like the FTA, ABS, or if you're using a different test. I will say that there is a new CLIA-waived rapid syphilis test that can be done at the point of care. Results are available in 10 minutes, and they have great sensitivity and specificity for detecting treponemal antibodies. So really, really cool that we can do that at point of care now. And let's see, let's go on to kind of the timeline and the natural course of syphilis as it relates to titers. So you have the RPR, you have that up and down RPR that helps us know the level of activity of the syphilis in the body. And then the FTA test or the treponemal test that can be done in, that's qualitative, it is going to become positive and stay positive over the course of the patient's life, typically the whole life. All right. Let's look now at some false positive, because we always get the question, a patient has a positive RPR, they have a reactive RPR, and let's say it comes back at 1:1, a 1:1 ratio or a 1:2 ratio. In this case, this gets reflexed to a treponemal test, and the treponemal test comes back negative. So that is a case of a false positive RPR. There are many things that can cause a false positive RPR. I listed some of those here. Pregnancy is one of them. So you can imagine what happens when we're screening all of our pregnant women in their first trimester and that first visit. Many times there's a scare in there where the patient will have a positive RPR, and as we wait, because the FTA comes back a little bit later, once that FTA comes back, we see that the FTA is negative, and that means that this is a false positive, and it's probably caused just by the pregnancy. There are other things, advanced age. So many times we'll have, even patients up into their 80s being screened for syphilis, and they have a positive RPR with a negative FTA. That just means, it's a false positive. When we're looking, I want to note, so on the left, you see this table of titers. This is how the dilution is measured when you're talking about the RPR. Significant changes in the RPR require a fourfold either increase or decrease. So if I'm looking at a patient, if I have a patient and they have a 1 to 16 RPR titer, when I treat their syphilis, I'm going to consider a significant change or a successful treatment at a fourfold decrease in their titer. So if their titer goes from 1 to 16 to 1 to 4 the next time I check them, that's a successful treatment of syphilis. And we're going to talk about that just a little bit more here on our next slides. All right, so this is an algorithm that we use. The traditional one on the left is what I'm using currently at our site. So we do an RPR. It's manually read as positive or negative, and that's by dilution. And then if it's positive, it gets reflexed to a treponemal test. And if that is positive, the patient has syphilis, past or present. You are going to look at the quantity of the titer to have an idea of the stage of their disease, but also then assess the patient's symptoms, chancre rash, no symptoms, stage them, and then their stage is going to determine the course of treatment. The other option is the reverse sequence. So instead of doing the RPR first as your screening test, doing the treponemal test, that's an automated test. That test, if positive, gets reflexed to an RPR. And if your RPR is positive, then you know that syphilis is present either now or in the past. If the RPR is negative, then you're going to do, So at the first, I think I might have said it, the treponemal test, but in the first part of this algorithm, you're using an EIA test. So if your EIA is positive, the RPR is negative, then you're going to do the treponemal test. And even with a negative RPR, if your treponemal test is positive and the patient has never had syphilis that you know of, as far as knowing they had syphilis or getting treated, you're still going to consider them a syphilis case and treat them as a latent syphilis. So treatment is pretty standard. It is on the top left, you can see primary and secondary syphilis. This is for the non-pregnant patient. This includes patients with HIV. We're going to treat patients with primary or secondary syphilis with 2.4 million units of penicillin in a single dose. Single in quotes, it's usually 2 injections. The alternative is to give them doxycycline, 100 milligrams twice a day for 14 days. And then our other alternative is to do ceftriaxone. We really try to avoid this and use penicillin when we have it. And if not, use doxycycline as a second line or first alternative. When we look at latent syphilis, the treatment is a little bit different. This is going to be for non-pregnant individuals, including those who have HIV. We're going to give penicillin 2.4 million units as a single dose in the early latent stage. And for late latent, we're going to do 3 doses of 2.4 million units at 1-week intervals for 3 weeks in a row. So 2 shots once a week for 3 weeks in a row. And this is really important when you're educating your patients on treatment, because if they skip a dose and they're late by more than 4 days, they have to restart the whole treatment over, even if it was their last shot. So that's really important. For the alternative treatment, if penicillin is not available, or you are saving penicillin for your pregnant patients potentially, or other high priority patients, doxycycline can be used twice a day for 28 days as the alternative treatment. For late syphilis, that is cardiovascular manifestations. You're going to, this doesn't include neurosyphilis, you're going to do the penicillin for a total of 7.2 million units, but you're going to divide that over 3 weeks, weekly for 3 weeks. Now, neurosyphilis, ocular syphilis, otosyphilis, those all are going to get treated the same way. And this is going to be by IV penicillin. That is the recommended regimen. This is difficult for patients because it's given every 4 hours or as a continuous infusion, and it has to be given for 10 to 14 days. So most of these patients have to be admitted to the hospital unless you have the ability to do home IV antibiotics set up in your system. And I've had several patients that have been able to do that but for the most part, these patients need to be in the hospital for at least the beginning of this treatment until they can be taught how to do it on their own. But it's a difficult course, because you have to remember many of these patients, they don't feel sick enough to be in the hospital. Maybe they've just had chronic headaches, or they have some blurry vision. So it's a hard pill to swallow for them to have to stay in the hospital for 10 to 14 days. For primary and secondary syphilis in pregnancy, penicillin is our only option, because we can't give doxycycline, right? So for penicillin allergic patients, we desensitize them in the ICU, and they still get penicillin. So penicillin is the option for these patients who are pregnant. Okay, so just a few things to remember when you are treating syphilis. Patients require close follow-up. They need to have serologic testing afterwards, and we'll talk about that here in just a minute. But ideally, penicillin is the best treatment option for syphilis. And when we can use penicillin, that's what we want to use, even in penicillin allergic patients, because many times we can prove they aren't actually allergic to penicillin. For neurosyphilis, the durations are shorter than late latent syphilis. So you notice that for neurosyphilis, 10 to 14 days of penicillin is what's given IV. But after that treatment for neurosyphilis, something that often gets missed is that if this is a late latent neurosyphilis, you're going to want to follow up that 2-week course of IV penicillin with an IM dose of 2.4 million units of penicillin, benzathine penicillin, because that's going to complete their 3-week course for the late latent stage. Okay, and then for pregnancy, screening in that first trimester, repeating it in the third trimester is so important. And then we also screen at delivery in high-risk patients just to verify that they're negative, and to know if we need to intervene for the baby. Same thing for pregnancy. Even in women who say they're allergic to penicillin, we still we desensitize them, and that's done in the ICU typically. And still treat them with penicillin. Okay, so what are you going to do for follow-up after you've treated somebody for syphilis? In the early stages, for primary and secondary, if the patient's HIV negative, you're going to see them back in a week because they probably have a physical, a physical rash or a chancre that you need to follow up on. And then you're just going to repeat the RPR at 6 and 12 months. And then also you're going to want to make sure that you've done HIV testing and repeat that testing again at 6 months. For early primary, secondary syphilis and HIV positive persons, same thing. You're going to see them back in a week to check on their clinical exam. But then the frequency of follow-up RPRs in patients who are HIV positive is increased. So you're going to have that 3 month, 6 month, 9, 12, and 24-month check. And that is, you're going to see that in patients who are HIV positive with syphilis, it takes a longer time for their titers to come down, and the patients may need to be retreated during the course of their follow-up. For latent syphilis, which is either early, late, or unknown, you're going to repeat the RPR at 6, 12, and 24 months. And usually at the 12-month mark, their titer is not detectable. But if it is, even up to 24 months is okay, as long as you've seen a 4-fold decrease in their titer. So like I said, a 4-fold decrease in that titer, so 1 to 16 to 1 to 4, 1 to 32 to 1 to 8, that's going to be considered a successful treatment. Clinical cure, your treponemal antibody test is going to be positive for a lifetime. We consider treatment failure in patients who don't achieve that 4-fold decrease in their titers. And as far as the serofast state, so I included this information, but some patients with syphilis have an RPR that stays positive for a really long time, can be years. And as long as it's less than 1 to 8, and they had a 4-fold decrease in their titers, it's okay. These patients, I would make sure that they've been tested for HIV because it is more common in patients who have HIV. But there are patients who we consider serofast. Never forget about the treatment of syphilis contacts. So if they've been exposed to unknown latent syphilis and it's been greater than 90 days, you're going to treat based off their screening test for syphilis. But otherwise, sexual partners that have been in contact with somebody who has syphilis in the past 90 days, either primary, secondary, or early latent, need to be treated no matter what their results of their test are. I would treat those patients. And then also treat presumptively if it's been greater than 90 days, but you can't test them. You don't have the opportunity to test them. I would just treat them just in case, especially in our known syphilis outbreak that's happening now. And if they've been exposed to unknown latent syphilis, those ones, if they want treatment, can be treated as well. Okay, I think I'm going to skip this case. I'm going to, go to these pearls. So this is syphilis pearls. I just wanted everyone to have a copy of this slide, but serologic results are non-reactive in up to 30% of patients who have primary syphilis. So testing needs to be repeated in 2 weeks if your initial test is non-reactive. The non-treponemal test titers decline rapidly after treatment, but they also can decline slowly even in patients who are not tested. Remember that the treponemal test will be reactive regardless of the treatment history. So that means if somebody has a treponemal test that's positive, but an RPR is negative, and the patient tells you they have no idea, they've never been treated for syphilis, they should be treated for syphilis because they still have that potential to develop tertiary syphilis in their future. And just keep in mind that there are several syphilis tests at our point of care tests that are now available. So, so that's an option if your facility wants to go that route. And then regarding neurosyphilis, there is no standard test for diagnosing neurosyphilis. It's a combination of lab tests, clinical signs and symptoms. If you have a patient who has syphilis, who has a neurologic complaint, such as double vision or headaches or neck pain or neck stiffness, I would consider that patient to have neurosyphilis until you can prove otherwise. And proving otherwise is really hard to do because even with a normal LP, sometimes you can't completely rule out neurosyphilis. The treatment is difficult, but it's better to treat than to not treat in the case of potential neurosyphilis. We didn't talk about CSF, so I'm not going to go over that information for the sake of time. But just remember, there's lots of opportunities to screen for syphilis, and that's the first step in knowing your patient has syphilis is screening them because they don't have symptoms. Anytime somebody's had a positive STI diagnosis, you're going to want to screen them for syphilis. So positive chlamydia also needs syphilis screening. Any new patient that you see, because of the high risk group that we're seeing and the increase in AIAN population, every new patient should be screened for syphilis at that first visit. Consider it in your annual visits because we're not good at taking a sexual history and patients could be at risk and you not know. For prenatal visits, it's very important. Even for postpartum visits, it's a good time. Any family planning consultations, it's a good time to screen both parties for syphilis and other STIs. And then anytime that somebody's requested an HIV test, they should also be tested for syphilis. Okay, I know that's a lot of information, and this is a good time for questions. So Brian, do we have any questions? Oh,
We
you
don't
guys
have any
screen with
questions in the
RPM.
chat right now, but people are welcome to unmute themselves and ask their questions at this time.
Okay. Are you guys seeing a lot of syphilis at your sites?
I know a couple of them said that there were increased cases.
Okay. Well, so anytime I will say that anytime you have questions about a syphilis case, maybe about diagnosis or staging or even treatment or desensitization, if you have penicillin allergic patients, Dr. Mara and I are happy to take those questions through ECHO. You can relay those to Brian Hendricks, right, Brian? And he can get those questions to us. And a lot of times it just takes a quick consultation, but we're happy to answer syphilis questions anytime that you need a resource for syphilis if you're not used to dealing with syphilis.
I don't hear any questions or comments. Erica Pitts said no in Northern Virginia.
Okay, good.
Yep. Okay, well, we can go ahead and end. Please fill out the evaluation that's in the chat box. Just click that link and it'll take you to the survey. Next month, we're doing influenza as our topic. Dr. Mayer will present on that. Yes, excellent presentation. Thank you so much, Whitney.
Oh,
Uh,
thank you.
Yeah, I'm sorry to
um,
be chiming in kind of late. I was struggling to get my mute off. But you know, we have seen an increased rise in syphilis here within our community. And the struggle that we seem to be having, and I don't know if anyone can provide any feedback, is how to treat on a regular basis our unsheltered relatives. You know, and so that seems to be where we have a big struggle, because I know a couple of the cases we've had recently have been our unsheltered relatives, and just trying to contact them has been extremely difficult. So I don't know if anyone can shed any light on what you're doing within your communities that might help us treat our population that we're struggling to even get a hold of.
Yeah, so just to ask a follow-up question to that. So you're talking about patients who you know are positive for syphilis, but after their testing, you can't reach them?
Yeah, we've had a couple of them that were discharged from hospital settings. They were tested within the hospital setting and came back positive, but were not treated before they left AMA, and so they didn't receive treatment. And so just trying to, you know, just outreach with this particular population has been a tremendous challenge.
Yeah. Yeah, I will say you're not alone. You know, we struggle with very similar situations. I think that one thing that's been helpful in our case, we have access to like community health nurses who can go out to, you know, find people, but even that is many times not successful. So if you have that available, you know, that may be an option. And then getting the state health department involved. I mean, these are reportable, like we're required to report these to the state, at least, you know, not all tribes do that, I know, but the state can be a good resource in this situation as well, because they can help if they're seeking care outside of your facility, or outside of your health system. You know, that can be helpful as well. But yeah, mostly going to the patient is the best thing that we have found, making home visits or family member visits.
All right, thank you.
Mm-hmm. I know that's not a great answer. It's just really hard.
Yeah, I think if there was a great answer, we wouldn't be having that issue we have. And I know it's not just within our community, it's probably nationwide actually. So
Yeah. And I will say that, you know, if you're not seeing a lot of syphilis, I would encourage you to screen more, because probably if you're not seeing it, it's because you're not screening enough. And we're finding that in a lot of our clinics that, you know, they're maybe they weren't seeing syphilis, and we started screening everyone in primary care, and suddenly they are seeing syphilis, because we're seeing latent syphilis that, you know, it's old syphilis, and patients still need to be treated. So, so yeah, I encourage you to screen more, screen every patient that, that comes across your, you know, across your exam room, into your exam room, so that you can, just confirm that they don't have syphilis.
And just one other thing, we did have a clinical training that was supposed to happen next week in Miami, Florida. We have had to postpone that due to the weather. the Hurricane Lee that's coming up the coast. So we will reschedule that for January or February. And don't forget to fill out your feedback survey. Anything else? Okay. Well, you all have a great day, and we'll see y'all next month. Whitney, can you stay on a second?
Sure.